So, hello everyone, and welcome to our salon, which we're having for our MBU, the Mother and Baby Unit's Special Interest Group, is having another salon to talk about MBU type services all over the world. So, thank you so much for taking an interest in our Special Interest Group and for taking the time to come and listen to us. We're recording it, so if you're here and you're with us and you want to participate, be aware that we are recording it, and the recording will go up onto the Marcé Society website, as well as being available elsewhere. And hopefully it will be an interesting talk. So you should be expecting to hear two talks today. So we're going to hear from Anne-Laure Suter-Delay, as well as from Dr. Medri. But unfortunately, Dr. Medri is not well, so she's not going to be able to present her talk on this occasion. So we're just going to hear the one talk today, and we will hopefully hear from Dr. Medri and from her work in Massachusetts another time. But we'll keep it in store. So come back and listen to the next one another time. I think that'll be really helpful and really useful talk to hear in the future. I just want to start really by just setting out what we've been doing and to thank everyone for coming, but also just to recognize that the really hard work which has been going on in our special interest group over the last 2 years. The reason we set up this special interest group is that we were acutely aware that perinatal mental illnesses affect lots of women all over the world in lots of different ways. And we also were aware that there's always going to be that group of women who suffer from the most severe forms of perinatal mental illness. And we really wanted to make sure that we didn't miss them. We wanted to make sure that they have a special space where we can consider how are their needs met? How do we make sure that they really do receive the very best care? And I suppose coming from a UK background and working with Berid, whose idea this was in the very beginning, so thanks Berid for being with us as well. But what we really said at the very beginning was that, well, mother and baby units, because that's what we know and that's what we love in the UK and in England. But very quickly, once we had our very first meeting back in Barcelona in 2024, we heard how we had our colleagues working all over the world, already working with this particular cohort of women, but working in really different ways. And so although this is called the MBU Special Interest Group, that's really just a shorthand. What we're really saying is that we want to know, how do we really care for and treat women suffering from the most severe forms of perinatal mental illness? And what we've learned over the last 2 years is that that's being achieved in lots of different ways, in lots of different areas. And so the point of these salons really has been to share some of this knowledge, some of this experience that we've been able to gain over the last couple of years with the wider Marseille society, so that we can share, actually, this is what's going on all over the world. And this is how perhaps we can learn from each other to think about the very best standards of care that we can be offering this particular cohort of women. And so with our special interest group, we've continued to meet on a monthly basis for the last couple of years, and we've been holding 2 meetings twice a month. So one meeting for the western half of the hemisphere and another meeting for the eastern half of the hemisphere. And as a result of that, we've been able to get people from literally all over the world. So we've got, I think I was totting it up earlier, but we've got tens of countries that are actually represented, as well as having lots of clinicians from all over the world. So we've got over 30 members who come actively to our groups, as well as having representation from lots of corners of the world. But we're always looking for more. So if you'd like to join our MBU Special Interest Group, please do. We're a very friendly bunch. We'd really like to meet you, and we'd love to hear a little bit more about the experiences of how you're treating the women in your particular area. And again, just so we can share this knowledge and hopefully learn a bit more about what else we can do, how we can make this even a better experience for our women who are struggling at a really important time in their lives. So come and join us. Hopefully, we've got another MBU Special Interest Group meeting. It'll be set every month. It will be on the Marseille website, so you can have a look at when those dates are. If you're struggling in finding them, then type in, write to Lauren. She'll be very happy to let you know when the next meetings are, and you'd be very welcome to come. And obviously, we will all be going to Cape Town for the Marseille Society International Congress, and we will definitely be having a good representation from our special interest group. So if you don't join us before then definitely come and say hello to us when we see you in Cape Town. We're looking forward to doing that. Okay, so I think that's probably enough of a plug for our special interest group. I will now hand over to Professor Anne-Laure Suterdele. I'm sure I'm not saying that terribly well. I'm really sorry. I'm not, but please do tell me how to say it better. But who's going to tell us a little bit about the services that she's been running over in Bordeaux in France, and then hopefully we've got some time at the end to have some question and answer to think how can we learn from each other again. So what else could we do to really understand how these services work? So, Anne-Laure, I'll hand over to you. Thank you very much.
Thank you, Gilles. Thank you, Vered, also for organizing this group, which is very interesting and helps us to share the knowledge all over the world. So I think it's a very nice group, and I agree with Gilles, come with us. So thank you for giving me the opportunity to present to you today our regional perinatal psychiatry department, which is in the University Department of Child and Adolescent Psychiatry in Bordeaux. This department was established over 30 years ago as a small liaison psychiatry unit which was set up following my medical thesis on postpartum blues at the request of the obstetrics teams, who quickly recognized the major importance of maternal mental health in their everyday practice at that time. As we were starting from scratch, we had every opportunity to think about and organize this department according to the needs of the region, taking into account the data that we had seen emerge over time, particularly that from the Bauer report on the cost of perinatal psychiatric care, which showed us that more than 70% of the costs were related to the child development in the context of parental mental illness, but above all, that good organization of care costs 5 times less in the long term than doing nothing. As we had been asked by the obstetrics teams to set up a screening and prevention program, our department organized itself to respond in a coordinated and graduated manner based on the 3 levels that define mental health according to the World Health Organization. The aim was therefore to be able to integrate into usual perinatal care and to propose care pathways ranging from positive mental health to serious psychiatric disorders, including psychological distress, which are very common in the perinatal period, as you know. Indeed, we all know that during this period of life, extremely serious conditions can arise very abruptly, putting the lives of both mother and child at risk. But also, this episode can be resolved very quickly if the treatment is appropriate. Oh, sorry. It was also necessary at this time to take into account all the specific dimensions of perinatal psychiatry. The first is that we must treat 2 intertwined and interconnected human beings for whom the same care can sometimes have different effects. We also had to take into account the different stages in order to be able to meet both the needs during pregnancy and after childbirth. While the definition of pregnancy was not a problem, of course, the definition of postpartum was not consensually defined at that time, since in obstetrics, it goes until the return of the period, while the DSM and ICD-10 give 4 or 6 weeks, and the World Health Organization gives 1 year. Today, it is simpler. The perinatal period is considered to be from the beginning of pregnancy to 2 years of age, with the famous 1,000-day period. Our pathways also had to take into account 2 types of populations: patients with a history of mental health, for whom we had to develop secondary prevention measures, which we very quickly directed towards multidisciplinary preconception consultations. On the other hand, we had to be able to respond to a primary prevention approach for the general population, and therefore put in place screening measures mainly during the maternity stays. Finally, we also needed to develop skills to respond to both acute disorders, such as mood disorders and anxiety disorders of the perinatal period, and also offer specific care for patients suffering from chronic and long-term psychiatric disorders, with here a particular focus on supporting the skills of these very vulnerable parents. And of course, we couldn't forget the father, the family, and the environment. So we had to respond to every situation and every question and every aspect represented in the diagram you see on the diapositive. I might as well tell you that when the psychiatrist, the child psychiatrist, the obstetrician, the pediatrician, the social worker, and sometimes the family had to agree on a care plan, we sometimes witnessed rugby scrums. We are in Bordeaux, where everyone had a perfectly legitimate point of view from their perspective, but which did not correspond to that of the other professionals. So based on all this knowledge, we are now fortunate to have built a department that offers our region coordinated and graduated care pathways, which are fully integrated into standard perinatal care and which I will now present to you in more detail. So to begin, a little geography. Bordeaux is located in the southwest of France. The mother and baby unit of our department is the only one for a region that covers an area representing just under a quarter of our country. It is therefore a very large region with 20,000 births per year. Needless to say, it requires very close coordination of care pathways in order to meet the needs of the population as closely as possible. And to illustrate my point, I will refer to the clinical situation of a patient who lives 200 kilometers from Bordeaux in the Basque Country. So this is Mrs. Aim, aged 32, who has been suffering from bipolar disorder for 10 years and is being treated effectively with lithium salts. She was referred to us at 36 weeks of pregnancy by her treating psychiatrist to the monthly multidisciplinary consultation meeting organized by the department resource team of our department, of which we have just a photo taken this morning here because we had the meeting this morning. This resource team is organized around the monthly multidisciplinary consultation meeting via video, which brings together all the maternity wards and perinatal psychiatry teams of the region. We are about 10 teams, something like that. It depends on the months. During this meeting, we discussed the most complex situations that the local teams have been unable to resolve with their own resources. And we then work together to define the appropriate care pathway for each situation and the necessary coordination between partners. The other mission of this team is to offer preconception or prenatal consultation for stabilized patients who are planning to become parents. This also involves offering secondary prevention pathways to avoid relapses and working with the couple to define the appropriate and the best treatments for the mother and the child based, of course, on a risk-benefit discussion. So if we turn back to our patient who was referred to us through this meeting, she had a consultation with our coordinating nurse who identified the depressive relapse that had been developing for months with suicidal thoughts in a patient who had a wanted pregnancy that occurred in a stable relationship. She abruptly stopped her treatment when she found out she was pregnant, fearing the effects of prenatal lithium exposure. So this patient's clinical situation required full-time hospitalization, so she was admitted to the wards to the mother and baby unit. She therefore traveled to Bordeaux to arrive at our hospital. Here you have an overview of the hospital, and in the hospital we are here. We are on the second floor, which is not ideal, but we exist, so it's a good thing. We are in a building that houses numerous adult psychiatric care units, a day hospital for bipolar disorders and the hospital's ECT unit. The unit is integrated into adult psychiatric services with all the necessary resources. So Mrs. M will therefore be hospitalized in one of the 4 beds reserved for pregnant women or for mothers hospitalized without their babies in the unit, when the baby are hospitalized in the neonatal unit, for example. These are patients with severe psychiatric disorders who may be hospitalized under compulsion if they are not dangerous for the other, of course. The objectives of this hospitalization are to implement treatments adapted to pregnancy based on a risk-benefit approach, and at the same time to offer specific monitoring of this pregnancy, thanks to the presence in the unit of a midwife coming from the maternity wards, who is working 20% of her time in the mother and baby unit with us. Of course, all this care is combined with psychotherapy tailored to individual and familial psychoeducation, for example, appropriate to the perinatal period, and partners and families are included in the process from the outset. Around this in-hospital care, we also always very quickly put in place an appropriate care pathway based on a multidisciplinary network involving the treating psychiatrist, the GP, and all the external services involved or whose assistance will be needed later in the care process. And above all, we organize the patient's obstetric, pediatric, and psychiatric care pathway for these pregnant women in collaboration with the midwife seconded to the maternity ward, so that it is tailored to her specific psychiatric, obstetric, and neonatal situation. So you have to know that in our region, all maternity wards have organized themselves to provide maternal mental health, which is very good, and care are based on their local resources in perinatal psychiatry. In Bordeaux, as we manage the only MBU of the region, we are called upon to deal with the most complex situations involving pregnant women, and we therefore need to work very closely with the maternity services, which fortunately are just across the street. This maternity ward is one of the largest maternity wards in France, handling some 6,000 births per year, and is the region's referral hospital also, where all the most complex obstetric and pediatric cases are treated. When I say at the beginning that our care is integrated, I mean that it is a reality in terms of collaboration, of course, but also in terms of architecture, as we have a liaison psychiatry team and a day hospital located at the first floor of the maternity ward. The liaison perinatal psychiatry service is organized as follows. Every morning from Monday to Friday, a nurse makes the rounds of all the floors and discusses with the midwives the need for intervention by our team. Then the nurse, the psychologist, the psychiatrist, and the resident hold a daily staff meeting to define each other's indications, which can be consultation, guidance, mindfulness therapy, relaxation, or consultation with the psychologist or the psychiatrist. In addition to this daily activity, there is a weekly medical psychosocial staff meeting, very important, that allows us to define in a multidisciplinary manner and as early as possible in pregnancy, the management of the most complex situation. We deal with approximately 600 situations per year, to give you an idea. This staff meeting brings together, of course, our team, but also the social team, certain external partners involving perinatal health, like maternal and child health services, and the obstetric and pediatric teams. So, come back to our patient. This situation was therefore presented to this staff meeting during her stay in the mother and baby unit to anticipate the delivery and the early postnatal period. So when she reached full term, she was immediately monitored by our team, and a prolonged state was planned from the outset to monitor her mental health and the neonatal adaptation of the baby with the pediatricians. Unfortunately, in this case, and despite our best efforts, this patient suffered a relapse, a mixed form, and after meeting with the father, we decided all together to hospitalize her and the baby in the unit. She therefore returned to the ward, but this time to a room next to one for her child. So the unit for mothers and babies is in the same place than for pregnant women, but we can accommodate 5 to 6 mothers and their babies up to 1 year of age for severe psychiatric disorders, but also for serious interaction disorders or for assessments requested by child protection services to help with decisions regarding foster cares sometimes. During these hospitalizations, mother naturally receive appropriate and adjusted psychotropic treatments, of course, particularly if they wish to breastfeed. These treatments will also be adapted to the mother's need for vigilance. And if they are too sedative, the team will take over care of the baby in conjunction with the father or the family for as long as necessary. Can be day, and can be during the night also. It depends on the situation. Care for the mother naturally combines individual therapy with group therapy, and for the children, we carry out a systematic assessment of their psycho-emotional and motor development, and offer all babies also video recordings of interaction with the mother, sometimes with the father also, which we rate using the Lynn-Murray's global rating scale. This is also specific care. There is also specific care for infants, focusing on psychomotor development and interactions through video feedback or therapeutic groups tailored to their needs and age, of course. This care is accompanied by significant work on social integration, thanks to the presence of a full-time social worker in the department who helps us to develop a plan for returning home as soon as the dialysis is needed. The work focuses on the quality of the environment, in particular the presence, skills, and mental health of the father and other family members, as well as the involvement of external partners, all with the primary aim of preserving the child's long-term health and overall development. So for this mother, in addition to treating a mixed episode, the lack of social support has been highlighted, and we will therefore work to provide her with an external support network, of which the attending physician and psychiatrists are an integral part, of course. After 21 days of hospitalization, she is stabilized and she can return home, but still needs support with interactions with her baby, which will be provided at the day hospital 2 days a week. In the region, perinatal psychiatry teams offer also either this type of care or home visits, which allow for the quickest possible return home after hospitalization in the mother and baby unit to preserve the family dynamic around the arrival of a child in a family. So I will take the example of Bordeaux. As I mentioned, our day hospital is directly integrated into the University Hospital maternity ward, which is extremely effective because it allows mothers to visit the facility while they are still in the maternity ward if needed. This means they are much less apprehensive about returning to a place they are familiar with, and which also is not a psychiatric hospital. We can see 6 dyads per day, and this facility, which is open 5 days a week, receives mothers suffering from moderate psychiatric disorders, as well as children with somatic vulnerabilities like premature babies. We also look after attachment disorders, migration issues, personality disorders, and so on. Of course, not all mothers come from the maternity ward. They may also be referred later to us by pediatricians, GPs, fellow psychiatrists, or social services, and so on. Finally, as I mentioned, we have many mobile teams in the region who can visit patients at home or in maternity wards. And until now, our mobile team consisted of 2 nurses, but we just get funding to strengthen it with a childcare assistant, a psychomotor therapist, and what we call a TISF, which is a social worker who can help mothers with everyday tasks, organize administrative tasks, but also look after the baby while the mother will rest or accompany her to consultation and so on. So I hope it will be very helpful to shorten the duration of hospitalization in the mother and baby unit. So Mrs. M's baby is 1 year old and doing well. The quality of interaction is entirely satisfactory. The patient is normotimic and is being monitored regularly. We are giving her the contact details for the service so that next time she can have a preconceptional consultation, which will greatly increase her chances not to have a perinatal relapse. Finally, and to conclude, I would really like to emphasize, if I have not already done so very clearly, the need for coordination between professionals from different units involved in each complex and severe case of maternal perinatal psychiatric disorders. The child unit, the day hospital, the liaison teams and resource team. For us, if each of these units worked independently, they would certainly not be as effective. So the department is therefore organized not with structures working alongside each other, but with structures interacting on a daily basis, organized around the medical and psychosocial staff of the maternity ward and the regional multidisciplinary consultation meeting, because it is in the maternity ward that all patients will be at one point or another, and where we can truly guarantee continuity of care for the mother and the baby. It is on this type of population-based model of care pathways in perinatal psychiatry that the Ministry of Health instruction is based. This law, very recent, to 2022, defines in France perinatal psychiatry as care for couples from the period prior to conception and for parents suffering from mental disorders due to psychosocial or environmental conditions that make them vulnerable in their parenting role and towards their children, particularly when the children suffer from somatic disorders. So in perinatal psychiatry, even if in very serious disorder, we can take primary and secondary preventive measures that are extremely effective, really. I can tell you it's sure. However, this requires anticipating situation and coordinating care pathways. And as I have already said, if everyone gives their opinion to the patient without consulting each other and without coordination, the care provided will look something like this, whereas what would be expected for the healthy development of the child and good maternal health would be something like this. So thank you for your attention, and below you will find a YouTube teaser presentation of the department, which is in French, of course, but the images give you a good idea of what this regional perinatal psychiatry network for Southwest France is about. Thank you.
Perfect. Thank you very much, Anne-Laure. That was a a really fascinating talk covering such a wide range of services, which you've clearly been developing over a long period of time, so over the last 30 years to bring this all together to make it work. And it sounds like it's working really well, which is fantastic. So well done. That's great to see. I'm sure that we will have some questions from our audience. So if you have got questions, raise your hand and I'll try and get to you, or pop them in the chat, which I can't actually find at the moment. But I'm sure that it's one of those buttons at the bottom. I will find the chat in a section in a bit. Maybe not quite yet. So shall I start though with questions, if that's all right, Anne-Laure, if that's okay? Sorry. Yes. Sorry. I, I got excited. I got excited. I'm sorry. I will slow down.
You.
So the question I was going to ask was, you cover a large chunk of France. So do you offer any support in terms of travel? So for families to come and visit, or for fathers to come and visit, is there any help for that, or any way to make sure they stay connected, or any accommodation that you can offer for fathers or the extended family?
Yes, for the fathers, we are organized with a place not far from the hospital, which is for all the parents of children who are hospitalized. Also, as I explained, the hospital, the university hospital, is for all the region also. So there are infant children who are coming from all the regions. So we have a special place for that. So the fathers can come. After that, the social teams from the place where the mother comes sometimes can help for traveling, but there is nothing organized especially for that. That's a shame, and that's a limitation. But as we are working with all the other teams, sometimes the mother didn't plan to come, but the most part of the time, the most of the situation, the mothers know before and months before that if they need, then they can come to us, and so they are organized in their mind to plan with that and with the family. And that's the reason why we made the teaser, because when you are living in Bayonne, it's impossible to come to visit, and I think people need to know where they go. So at the beginning, we had the computers, and we made with a video in the unit like that, and we made the teaser to help us to have a representation of what will be offered to her, and it's very, very helpful.
Yeah, fantastic. And so in total, you have 9 or 10 beds, is that right?
Yes, that's
Yeah.
it for the mothers, and 5 to 6 beds for the babies.
Ah, okay. Oh, okay. And so I was going to ask, how rigidly do you stick to the split? So in terms of having antenatal beds or postnatal beds, but it's to do with having a bed for the babies. So you can't admit you can't admit more women with babies now. So it's always going to be 6. Okay.
Yes,
Okay.
that's it. Sometimes we can have pregnant women in a mother and baby bed for the mother, but not in the other side. We just can have 5 or 6 mothers and baby, but
Yeah.
if we have a room left for a pregnant woman, we can do it, not for the babies. In maximum, it's 6.
Got you. And then there are 6,000 births in your hospital. How many births are there across the whole of that quarter of France that you cover?
Something like I said it, 20,000 in
Okay.
the whole country.
Okay. And so
So
do you have enough beds, do you think? Have you got enough beds for your population?
uh, it depends.
Okay.
Sometimes there is no one in the beds. It can arrive
Uh-huh.
less and less frequently because people know us now. So it's the main part of the time the beds are full. But I think that having more beds will not help us, because it's obliged also people from the different perinatal psychiatry teams to elaborate special care for the situation. You know, for the people to be in Bordeaux, it's a long way, it's far. You said at the beginning it's difficult to organize. So really, we just take the more complex and more severe situation, and we achieve it. It's sometimes difficult, but 5-6 beds, it's enough. And that's why we began with the pregnant women, because the more severe cases, we want to take them at the end of the pregnancy, so they deliver in Bordeaux with our liaison psychiatry team and come back to the unit. So that's very efficient, because we know the woman, they know the place, they come back to a place they already know, they prepared the delivery with the midwives from the unit, they know the teams of obstetric and pediatrics, so it's very secure for the women to be in this care pathway.
Yeah, so in the UK, the amazing Margaret Oates sort of told us how many beds we were allowed to have. And so we came up with the figure of 1 bed per 4,000 deliveries. And so that's pretty much what we've rigidly stuck to in the UK up to now. But I think the thing that you're doing differently is that you're also doing the social care assessments, so child protection type assessments, and you're doing that in the same space. How does that work out? How do your women find that, having some women admitted for an assessment of their parenting ability, and then other women being treated for schizophrenia or bipolar? How does the group get on the ward?
It's not really a problem, really, because I think the women who are in our mother and baby unit are very severe and complex situations. So the problem of help with the baby is always a problem. So I think everyone is concerned by a possible placement during the pathway. So it's not a problem, and I think the women helps together to understand why we are doing that. They speak a lot together. There is very a supportive group from the mother who are at the moment in the unit around that, and around child protection and child welfare and needs of the baby. So it's not a problem. Of course, sometimes it can be difficult because some women don't agree, and it can sometimes be violent, but we manage.
And how often do you discharge women without their baby?
I think it's not so in France we have the chance that it's not with or without. We have all the graduations, so you can be with your baby 1 day, 2 days, 3 days, 4 days, weekends, and so on. So I think that about 20% of the mothers they go away from the unit with a large amount of help, something like that.
Okay, great.
But also the work with the unit of perinatal psychiatry and the maternity wards of the region by the regional staff helps us also a lot to have good indication. I mean, when it's evident that will not be possible, we don't take the mother. We say it. We help the team to say, okay, you will have to manage. It's not necessary that they come because it's a contraindication. We will just separate the mother and the baby after 1 week of hospitalization. So no need to come, just do it where she lives, and organize with the family and meeting with the social workers and so on for the baby. So I think it helps us also to organize, and that's why I wanted to focus my speech on integrated, coordinated, and graduated cares, because really it helps us also to have only 5 beds.
Okay, great. Okay. And following on from that, then thinking about that integration. So Snehita's put a question in the chat. So Snehita's from our one of our MBUs in England. But she was wondering, how do you manage the transfer of obstetric care for women who were being admitted in pregnancy? And therefore, would all admissions in pregnancy, do they remain on your unit until the baby is born? Is it an automatic thing that they have to stay?
Yes, yes, they stay in the unit till the beginning of the delivery, but you saw it's really not far. It's
Mm.
just a few hundred meters from the unit, so it's not
But
a.
but in terms of transferring the obstetric care for the lady who was in the Basque region, so her obstetric care had been there and then was transferred to Bordeaux. How does that happen?
Yes, because the obstetricians are also organized in
Okay.
a network in France, in all France. You have level of
Okay.
care, level 3, level 2, level 1. And
Wow.
if there is a problem with women who was followed in a level 1 maternity and had problems, there is a
Wow.
platform, telephonic platform, where a midwife say, okay, you can go there because it's for level 2, here you have a place, or for level 3, and you have to go in Bordeaux. So it's organized, and we are
I'm
part of this organization. Psychiatric indication are taken into account in this organization of obstetrical cares.
I'm jealous, Anne-Laure. I'm sure Sunita is as well. So things don't run quite so smoothly sometimes in the UK. So that's nice. And from a funding point of view, from a money point of view, how does it work actually? And do you know? Yeah, how do patients pay for this? Or
I know we are public care, so it's
yeah,
a business Ministry of Health, like in the UK, I think.
so not quite. So in the UK, because we're all separate trusts, we do get into financial discussion about who's going to pay for these really complex women who've got very specific needs. And certainly in my previous role, when I was working in the UK, then my local maternity hospital would sometimes ask me, do you really need to transfer the obstetric care? Because this woman's going to cost us a lot of money. She has no capacity. We're going to have to go to court. We're going to have to pay for lots of things. And so they're not happy. Well, they weren't happy. But so money does play an issue for us in the UK, even though it's free for our patients. The trust, the hospitals do worry quite a lot about the finances.
No,
Not you.
the only, no, we have not this type of problem. Really, I
Nice.
don't care of the money when I give an indication of care for women, and I am very happy of that. And it's a
Good.
social security in France still remains. I hope.
Very good.
uh,
Okay. Yeah, no, Snehita and I are even more jealous right now. This is good.
just one dimension can be complicated. It is that in the maternity wards, they have the same amount of money if the woman stay 1 day or 10 days.
Yeah.
So
Okay.
when we say that we think that the women should stay in the maternity ward 10 days, sometimes they are not very happy. But at the end, we said it's a medical indication. You do what you want, but it's like a care. So of course, cares cost a lot of money. So sorry, but when you compare the cost of the maternal cares to what would be for the infant and their development at long term, so it's
Yeah,
not
no, I
interesting to do like that.
very nice. And I agree with the sentiment. So this is good. Okay. Good. Have we got any other questions that people might have for Anne-Laure? I think I've probably got one or two more. But any questions from anybody else before I take over completely? I was going to ask one more then, if that's okay. So so for this lady, she went back to the Basque region. So, and she went to the day hospital for 2 days per week. So that was in the Basque region. You have a well set up day hospital, just as good as your one in Bordeaux, but in a separate region. Okay, that's amazing.
Yeah, the region we are really organized, and we had a lot of colleagues who learn perinatal psychiatry and are working with us. It is the people who are connected with us every month, and we have or day hospitals or mobile teams or very acute liaison psychiatry units all in the region, yes. And if it
Brilliant.
would be like that, it would not be possible to have only 5 beds. We would need 10 or 15 or something.
Definitely. Yeah. And so your average length of stay, the average amount of time that women stay on the ward, you feel is reduced because of the day hospital.
Yes, sure.
How long is it? How long is your average length of stay?
1 month and a half.
Oh, that's okay. So 6 weeks. Okay. Yeah, it's pretty good. Nice. Okay. Any other questions then whilst we've got Anne-Laure with us?
Sorry, Johns, can I ask a follow-up question?
Of course you can. Yes, please do, Sunita. Yeah.
With the day hospitals, how long can women attend there?
1 year.
They can attend for a whole year.
Yes, one day or 2 days a week during 1 year, till the birthday,
Till the first birthday.
the baby.
That sounds fantastic.
Yeah. Very nice, isn't it? So, and then do you have much work from experts with experience? So, peer support workers, so women who have been through your system, who've been through the day hospital, do they come back and work with you and support women afterwards? Have you got a group of women like that? Yeah.
We don't have. We tried to do it, but it was a financial problem. The hospital didn't agree to support us to do that. They told us if women want to do, they have to do it by their own. But what we have is that the women are giving the name of the department to their friends, and so people come to see us. And I think that a lot of women who met at the day hospital keep in touch. We know that, but it's not official.
Got you. Okay, great. Okay. Any other questions then for Anne-Laure? Bered, go for it.
Well, I have a million questions, but I'm going to save them for Cape Town when we meet. I did want to add, first of all, thank you, Anne-Laure. That was very, very inspiring. Your model of care is really fascinating, and there's so much to learn from you. And I wanted to say in that account that we are having a survey. Giles was talking about our initial motivation to learn what other people are doing all over the world. So our survey is being passed around the whole world. We already have over 300 responders, but we're looking for an international coverage. Giles, you're welcome now to say your sentence about this. And we really, really want to know what everybody around the world is doing with this cohort of patients that really needs a professional and dedicated care like Anne-Laure just told us about. And
absolutely. So yes, we have got a survey which is going around, and we want to include as many people as possible. 300 people have already applied, which is amazing.
I think
Over
320, I think.
320, amazing. Okay. And we're going to publish it, and we're going to let the world know where all of these amazing services are for women with the most severe forms of perinatal mental illness, and what do they look like? Because that's what we really want to know. So if you've not already replied to our survey, this is your chance. You don't want to miss out. You don't want to be not included in this very first publication, which includes all the other top-notch services around the world. So make sure you fill out the survey so that we can collect it together and make sure that you're part of our family, part of our group. We want to show the world exactly what these services look like. So yes, please fill in the survey. We should have put the link up in the chat, but I don't have the link for the survey, I'm afraid. But we'll get it sent out, and it's on the Marcé website. So please, there's no excuse. Fill out the survey. It would be very good. And
Yeah.
thank you for the prompt ferret.
And I think we'll ask Lauren to put it together with our with the video so people can fill in. And also to say, people always apologize that they don't show up for all meetings. Every time anybody shows up for any of our meetings, we always have something new to learn from them. And even if you can come only once a year or twice a year, everybody is very, very welcome to our group, as Giles said.
Definitely. Yeah, come join the family. And Sunita, who's far more organized than I will ever be, is put up the link in the chat. So thank you very much, Sunita. That's great. So there's definitely no excuse. Fill out the survey. We want to hear about you. So fill it out and then come and join the group. We're a very nice bunch. Come and say hello. Tell us what you're doing. Tell us what's happening in your particular area. And then similar to what Anne-Laur's been doing, no, let us learn from you. So I think we've learned a lot from you, Anne-Laure. So thank you so much for sharing your story. Because I think what happens is unless we have this dedicated time, we all pick up snippets. We all have an impression of what services may look like in different areas of the world. But actually having this consolidated half hour or so of just going through it in detail has been really, really helpful for me to learn what you guys are doing. So thank you very much for sharing. And it's given us some room to be envious of what you're doing as well. But I'll get over it. It'll be good. And I know I'm talking too fast, so I'll stop. So thank you all very much. Thank you very much.
My English, it's a good thing.
Your English is fabulous.
Oh, yes, of course. That's evident. Thank you. Thank you.
Okay. Thank you all very much, people. Enjoy the rest of your evening. We look forward to welcoming you to our next salon, which will be not very far away. So we'll do it soon. We're trying to do them once a quarter. So no doubt there'll be another one in June. And if you've got things that you want to present, then tell us. If you want to tell the world about what you're doing, then I'm ready to hear it. Tell us about it and we will listen to you. Okay. Thank you very much. Have a good evening, everyone, or whatever time of day it is where you are, and enjoy the rest of the day. And I will see you all very soon. And if not soon, I'll see you in Cape Town. Okay, take care. Bye-bye.